Thank you, everyone. I'd like to thank Randy and Amy Bennett and her whole team for putting this together. They do a pretty good job of it, and I know we started this conversation probably about a year ago, so a lot of work goes into making these things happen. I'd also like to thank all of you for being here. I don't know when I signed up for this. I quite expected this many people. I figure they must be serving something new in the lunch boxes that draws you all in. All right, get started here. So today we're here to talk about the pelvic floor, and namely when things don't work right with the pelvic floor. We're going to do that in a few different ways. First, just briefly talk about what urogynecology is, what it is that I do every day and keeps a roof over my head. Secondly, we'll just have a brief overview of what the pelvic floor is so we have a good starting point to this conversation so that we know what it is, what it's supposed to do, and then be able to identify what happens when it's not working properly. And finally, we're going to talk about a few case reviews. So as opposed to me just standing up here and kind of droning on and mentioning a topic and going how we evaluate that one topic and treat it, we'll try and make this a little more human and personal and put it in the context of this is a patient that comes in with a complaint, and this is the process that someone might go through in evaluating it and treating it. All right, so for starters, what is urogynecology? So urogynecology started out as kind of amalgam of urology and gynecology, and even in some sense colorectal surgery. What was happening was you had urologists and gynecologists and sometimes colorectal surgeons all involved in the care of one patient and taking care of only one facet of their pelvic floor issue because that's what they were trained to do. As things developed, certain physicians decided, it would probably be good if we could just be a one-stop shop for all of this and deal with all things that are pelvic floor, and hence we developed a subspecialty. Now you can become a urogynecologist either starting as a urologist and doing additional training, or starting as a gynecologist and doing additional training. Starting in 2013, they developed an official board certification in this. I was certified in 2014. And hence, a lot of what I do is just take care of all issues pelvic floor. Now, specifically when we're talking about those issues, we'll be talking about either urinary or fecal incontinence, prolapse, so when things are falling down, or a number of other issues involving the pelvic floor, such as issues with pain or pain with intercourse, or retention issues. So, briefly, let's start with the pelvic floor, and I'm going to turn your attention first to this picture on the right side, because we're going to look at this picture in a number of different ways. So, just so everyone has a context for what we're talking about, this took somebody, cut them in half, straight down the middle this way, and currently she would be facing the left side of the room. All right, so here's the front of her abdomen, here's the back of her bottom. So kind of going front to back, here's the pubic bone. Directly behind that, you have the bladder with the urethra. Behind that, you then have the vaginal canal with the uterus, and then behind that is the rectum. And up here, you have the tailbone. So when we're specifically talking about the pelvic floor, we're basically talking about this area where I have the arrow. It basically makes this bowl that supports the organs of the pelvis, and that's a combination of different muscles and what we consider connective tissue, or kind of the stuff that holds us together. Now, the way that works is that pelvic floor functions to maintain the position of those organs and also control whether or not you can eliminate or not and control that function. The ability of it to work properly controls those issues. All right, I kind of like this picture because it shows that things aren't so simple sometimes. So one thing I'll have some people come in and tell me is that they have a problem with the nerves of their bladder because they may have been seen somewhere else in the past, and they want me to just go in and fix that nerve. Okay, this picture you see on the right shows that there's actually a lot of nerves involved. So what controls the function of your bladder and your pelvic floor is sometimes not so simple. It starts off with part up in your brain, cerebral cortex, which you decide you do or don't want to avoid, or you're taking your kids to school and decide, I need to wait until I get back home to go to the bathroom. Further down, you have what's called a Micturition Center, which is a fancy word for urination. It's in the base of your brain. That signal then travels down to your spine, and you have two different centers in your spine that then act based on what that area in the base of your brain tells you to do. Either are you storing urine, or are you eliminating the urine? Any dysfunction you can get anywhere along this pathway, whether it starts in the brain, the spinal cords, these nerve centers, or these peripheral nerves then affect how the pelvic floor and bladder work. So sometimes that like, oh, can you just go fix this nerve is not such an easy question, because you can have different issues like Parkinson's disease or multiple sclerosis that impact this. You can have people that have different spinal issues, either from traumatic injuries or spinal stenosis in their spine, or things such as pelvic trauma like childbirth has affected the function of these nerves and ultimately affect how their bladder and pelvic floor work. So they might come in having very similar complaints, but where the source of the problem might be very different sometimes. So it's really a complex interaction of how these nerve centers work in conjunction with the various muscles and the organs in your pelvis to make everything work properly. Now, how often do things not work properly? As Randy kind of already said, in general, when you pull the population, about 1 in 3 women have an issue with pelvic floor dysfunction, and that could be anything from incontinence to prolapse to pain. I frequently get asked a question after I've seen a patient, like, how common is this? Is this something we see a lot because nobody is talking about it? And I've heard of some things, but not many people know. This is actually quite common. Now, are 1 in 3 women all the time having to come in and have this actively treated? Not necessarily, but it's a fairly pervasive problem. When we get more nitty-gritty about it, in general, we're looking at about 18 million women in the country that have urinary incontinence issues. Again, that can be on a spectrum, but it's a profound issue. In regards to prolapse, generally we're doing approximately 200,000 surgeries per year to treat prolapse issues, and the cost of all this generally runs about $300 million per year. So it's not a minor issue. I mean, there's a lot of money, a lot of resources, and a lot of time that goes into dealing with these issues. All right, so with all that, we'll jump into our cases. All right, our first patient here is Mia Pian. All right. All right, Mia is coming in and has a very common complaint. I picked a couple topics that are very common complaints that people will start with. So her complaint is she will start urinating, it just hits her all of a sudden, and she can't stop it for the life of her. There's just absolutely no controlling her ability to urinate, and subsequently is now something that is controlling her life. So when you get more nitty-gritty, and when I'm asking these kinds of questions about, okay, what kind of triggers do you have, I'm basically trying to figure out what is it that's causing the incontinence issues? What kind of factors do I think are contributing? Because again, it can be fairly complex sometimes. So with Mia, she says specifically when she does anything like laughs, coughs, jumps, sneezes, or lifts, she tends to leak urine. So anything that is causing increases in pressure on her pelvic floor tend to cause her to leak. However, she also has a number of other triggers. So for instance, she'll wake 3 and 4 times a night to void. So sound asleep, not doing anything, just laying in bed. Her urge to urinate will get severe enough that she's getting up, having to run into the bathroom, and frequently dribbles most of the way there. So, not just when she's getting up and straining and causing pressure on her pelvic floor, but when she's doing nothing at all, she spontaneously will start to leak. Other things that tend to trigger this with her is she'll simply hear running water. So she could be doing dishes and all of a sudden start to leak. Or she could have just gone to the bathroom, gone to wash her hands, puts her hands under the running water, and even though she just urinated, she starts leaking again. Another really common thing that we'll see is people will pull into their driveway, trying to get into the house to get to the bathroom, and don't have a prayer. So this could be someone, and for instance, someone who just urinated before they left, say, work, drives 20 to 30 minutes to get home, gets in there, and automatically can't even make it to the house. I mean, keys are in the hand, trying to unlock the door, and it's all over. And finally, one of the things people tell me, and this is a frequent complaint, that they wait too long. Now, I will tell you, most people that are telling me they wait too long probably truly haven't been waiting too long. Okay, if you, like for instance, I will frequently get bladder diaries. So before some of the subsequent testing, I'll have people just keep a log of how often they're urinating, how often they're leaking, what their fluid intake looks like, and try and kind of clean up the picture of what's really happening here. I will have someone come in and tell me that they're waiting too long, but when they bring me their bladder diary, in truth, they're urinating every 30 to 45 minutes. Okay, I don't know that anyone would consider 30 to 45 minutes too long, but in the context of if they go longer than that, they start leaking, it is for them. So of course there are some patients that will come in and they might void 3 or 4 times a day or urinate 3 to 4 times a day. But there are most of them that will say, oh, I've been waiting too long. That's not the case. They're in there all the time. It's just they get in circumstances where they still can't get there fast enough, so they just assume that, oh, I'm too full and it's not going to hold. You know, because of all these reasons, it's not uncommon that people will map out basically where bathrooms are. So, and this can be a major factor in their quality of life. I mean, when these issues are severe, people tend to want to go to places they're familiar with. They tend to want to go to places where they know where all the bathrooms are and they feel secure. When it gets bad enough, they might be hesitant to even go out. I know I've had patients that they might come in with a friend, and their friend is saying, oh, we used to go out and do this and this and this, but now, you know, Sarah is only out for an hour and has to come back and is nervous to stay out any longer. So it really puts some stopgaps in your life and what you want to do. All right, as far as Mia's medical history, so when I'm looking through a medical history, one of the things I'm looking for, okay, what risk factors do I see? Can I identify risk factors that make me think this or that might be the cause? So when we're specifically talking about Mia here, 48-year-old, she's a mother of 3. Now, she does report that her first delivery was really difficult. She had a big baby, 9 pounds, and tells a long story about how big the head was and how she had this marathon of pushing to get that baby out. Okay. Pelvic trauma issues such as a difficult delivery definitely contribute to factors like this. Additionally, she says she's been smoking for about as long as she can remember. Now, this is an important factor for a couple different reasons. Okay. One is smoking does impair your ability to heal because you have impaired oxygen delivery to, you know, extremities or whatever organs. You know, it harms the vessels, you don't get as good a blood flow there, hence you don't get oxygen there, hence there's impaired healing. So if there was some kind of traumatic event that happened with your pelvis, things don't heal well in the first place. The other, and probably bigger contributor, is what happens when you smoke too long. You get lung issues. With those lung issues, you get a lot of difficulty breathing, chronic coughing, and when you're doing all those things, you get constant pressure on your pelvis. That constant pressure only aggravates the symptoms you're having. Now with Mia, she also, water for a second, works at Ford on the assembly line. So she has a fairly labor-intensive job. You know, such that, like, you know, people will say they're lifting car doors off of the line every day. The constant lifting is constantly putting stress on her pelvis, which is further aggravating her symptoms. Oh, thanks. She does have a few other little life factors that contribute to this as well. Again, I'm looking for risk factors here. So Mia starts off her day with a whole pot of coffee. Has been doing it for years. Okay. After her coffee, she likes a little bit of soda just to keep things going. Now, this little history right here, I would say, is not uncommon. I mean, I will see it probably a dozen times a week. You know, and I throw this quote in here. Actually, this is a quote from my father. So, but it's something that, you know, you ask someone who's drinking this much soda and caffeine and tea and say, like, have you ever thought about trying to cut back on this? Because if you know much about caffeine, it makes you have to urinate more. It's a diuretic. So basically, you're aggravating a problem that you already have. And some people, if you get them to stop the caffeine, they'll have a reduction in their symptoms enough that they won't really need to do a whole lot else for the time being. But it's a hard habit to kick. Really hard habit to kick, and hence like this quote, like, you try and get them to drink water and they're just like, no, I can't just drink water. Can't tolerate water, won't drink water, I hate water. All right, so now frequently when a patient comes in to see me, they might come in and not have done anything, just get sent in to me with fresh complaints, nothing done, but there are plenty of times where something has been tried. Because generally about a third of patients will come in and have had symptoms for about a year. A third might have had it between 1 and 3 years, and another third will be 3 years or greater that they've been dealing with these symptoms before they seek treatment. So there are plenty of people that will come in having tried something to manage this, because again, it can really control your life. So for instance, with Mia, she saw her primary care physician at one point, and they tried some medication. She did the medication. She didn't notice a huge difference. The one complaint she has about the medication, you tried it, maybe it did something, but it just dried me out. My mouth was dry, I was having to drink all the time to combat the dryness, and didn't feel like it was working that well. In addition, some people will try these poise and presses. So I don't know how many of you are familiar with those, but that's something that's similar to a tampon, except it has a little more bulk to it. So you place it inside the vagina, it expands and provides a little bit more pressure and support underneath the bladder neck, which can help with some of the incontinence issues. You can buy these over the counter, so there are plenty of times people will come in, have had incontinence issues, and tried these to see if there's something they could do with help short of having to go see the doctor. And finally, this is actually really common, I mean, particularly when you have incontinence issues as bad as me is that people are wearing a pad all the time. And they have a number of different poise pads depending on how much you might leak and how much it can absorb. So you can spend a small fortune on poise pads with these kinds of issues, and it's not uncommon to do. They've actually done cost analysis just based on use of pads compared to other interventions, determined, yeah, that's expensive. That's not a small amount of money you're spending. And Mia's final comment on this whole circumstance is she can't do this anymore. I mean, particularly like at work, on doing something like an assembly line, having to pee every 30 minutes makes things difficult at work. Leaking every time you're trying to do anything at work makes things difficult at work. Being hesitant to go out and do anything you want to do because you might leak significantly affects your quality of life. All right, so now we get to the examination. So, if you notice, Mia is only about 5'3", but weighs 210 pounds, which definitely puts her in the obese category. Obesity is definitely a big factor when we're talking about incontinence, and there's a number of different studies that show that if we can get people to lose weight, we can actually reduce their symptoms. Now, losing weight is frequently easier said than done. It's not something that's easily accomplished, and also it's not something that's usually drastic and quick. So someone has to really invest in that, be working at it, but you can see real differences. And again, the reason that works is because if you're heavy, there's a lot of pressure on your pelvis. There is always a lot of pressure on your pelvis. If that pressure on your pelvis is aggravating your bladder's ability to function appropriately and causing you to leak, you're going to leak more with all that pressure. If we can reduce that by losing weight, you'll get better. One of the main things too, we also rule out when I do an examination is make sure they don't have an infection. Okay, there's a few different reasons for this. One reason is incontinence issues can cause more infections. So we will see people with incontinence that are wearing pads regularly, having a lot of constant moisture, and they will have more infections. Additionally, one factor we have to check on is retention. Your bladder's actual inability to empty well can actually cause it to leak too. And when it doesn't empty well, it makes you more prone to infections. And on the flip side, these infections subsequently worsen the incontinence. So someone who's having recurrent infections, if they're not having retention, if there's not other factors involved, it could be simply the recurrence of these infections that's causing them to leak more and more and more. So we have to treat that, evaluate it, to move on. Now, as I already mentioned, I want to make sure that there's no retention issues. Okay? You can have a combination of different problems that cause you leak, retention being one of them. And most people that will come in with retention don't really know they have it. They'll go in, they'll go to the bathroom, they have some sense that maybe they didn't empty all the way. But they think, well, I think I am because I have all this urgency and I'm having to go all the time. Well, if you're only emptying your bladder, say halfway, it fills up that much faster and you're having to go that much more frequently. And then when it does start to leak, it's physically just overflowing. It's like the pot's now too full and it spills. One thing I obviously do too is try and see if I can reproduce the leakage. Okay, and there's different ways of doing this. Usually on the first clinical visit, it's more of like I will have them cough or sneeze or something of that nature when we're doing the evaluation to see, does this reproduce the leakage? Again, I'm trying to figure out what causes are contributing to the leakage. this is a big clue to, okay, is it a stress issue? Is it something where she coughs and lifts and that's provoking more of her problems? All right, so this is physically a picture of like what Mia's exam might look like. Now this one has a Q-tip in it. Not many doctors I know of are still using a Q-tip, but they classically call this the Q-tip test, okay? So you can see here the Q-tip is going into the bladder, so just orientation. Mia would be laying on her back, front of her abdomen. Again, pubic bone, bladder, the uterus with the vagina, the rectum, and the tailbone. Now, this is at rest, so Q-tip is coming out nice and straight, okay? However, if you have Mia cough or sneeze or bear down, that Q-tip jumps. It's almost like a conductor in front of an orchestra, all right? So when she bears down or coughs, this Q-tip goes up because the angle here at the bladder drops further into the pelvic floor, all right? We call this hypermobility, okay? So what this is telling me, in essence, is this area right here, right around the bladder neck, is not supported as well as it should be. Because normally if you have somebody cough or bear down, that Q-tip's gonna move a little, maybe 10 or 15 degrees, not 30 or more degrees. If it's moving 30 or more degrees, I can say, okay, this spot probably not supported as well as it should be. All right, and finally, okay, what are we gonna do with Mia? What do I, based on the physical exam, based on what we've ascertained from talking to her, what is probably going on and where do we start this process? So I'd say we're gonna start off with just one myth I'll frequently encounter. So a lot of people I will see in the clinic come in and think the bladder leaks and it basically leaks for one kind of common reason. And all the different treatments that they'll hear about are basically different ways to approach that one common reason, which is generally not the case. And Mia, in our example here, kind of portrays that. So one of the main problems that we see here is urge incontinence, or we'll also call it an overactive bladder. So what triggers us that might be going on is some of the symptoms where Mia all of a sudden gets urgency, can't make it to the bathroom fast enough for a variety of reasons. Either she hears the running water, or she's pulling into her driveway, or the fact that she's sound asleep and then suddenly is woken up and can't make it to the bathroom fast enough, okay? Those are all signs to me that we have a bladder that's basically developing spasms periodically. Forcing all the urine out even though she's not willing it to do so, okay? One of the things that's specific to these issues that we look for are different triggers. Now these triggers can be both physical or psychological. So for instance, when Mia pulls into her driveway, obviously nothing really that physical is happening to change what her bladder is doing, but there's a psychological trigger that she needs to go and has to now go. The running water is a psychological trigger. So one of the approaches to try to treat this is trying to also address what are the different triggers that cause the incontinence. Mia also has stress urinary incontinence. Okay, this is not emotional stress. This is like the physical stress of when you laugh or sneeze or cough and you have increases in abdominal pressure that then start causing you to leak. So, two different causes in her circumstance that contribute to her leaking, and to address her leakage, you actually have to address both causes. It's not, medication is not gonna fix her stress incontinence. So the approach of like, oh, just medication is gonna make this all better isn't gonna do it. We could improve her urgency perhaps, but probably not the stress. Let's start talking quickly about urge incontinence. So urgency incontinence I like to categorize more as a functional cause of incontinence. So what I mean by that is you can have all the support in the world around your bladder. It can be in the perfectly anatomic position, but it still leaks. Okay, and that's because its ability to store urine has been impaired. So this is a process where the bladder starts to fill. It doesn't even have to get to full, and it either starts having uncontrolled spasms or like a knee-jerk kind of reflex that cause it to empty, or you get different psychological triggers, kind of like what we had talked about, that cause it to spasm and then empty, okay? So again, this is not something where the bladder is not where it's supposed to be, and that's kind of another myth we'll encounter a lot, is a lot of people will associate, oh, my bladder leaks because my bladder's fallen, okay? Which is not necessarily the case. The bladder could be exactly where it's supposed to be and still leak, and we have to address those different causes. All right, Mia's other main problem was the stress incontinence. Okay, and you can see in this picture here, kind of describing the stress incontinence. So you have increases in abdominal pressure, push down on the bladder, the urethra and the sphincter, which is right here at the bladder neck, are able to compensate for that additional pressure, and hence urine leaks out. Okay, now, stress incontinence is a little interesting in the sense that most people think, oh, there's a sphincter muscle at the neck of the urethra. If it closes off, it should just be able to hold the urine, right? It's just a little O that closes, okay? That actually probably only contributes to about 35% of the reason that as a woman you can hold urine, okay? The other 65 is actually a function of the urethra itself, okay? Not with the sphincter muscle. And this is what this picture here is trying to show to some degree. So this picture is a little different, okay? This is like you're looking down on the pelvic floor from the top. So in this picture, you have the front of the pubic bone here. You see the pelvic floor here. This is the urethra, where urine is coming out. Behind that's the vagina, behind that's the rectum. So you're almost looking into a bowl from the top. This picture is showing this little area right here. See where the white tissue is? Okay, that's something called the pubourethral ligament, which is actually a combination of different muscles and connective tissue. That ligament basically makes a hammock. Okay, so if you could imagine a hammock below the urethra, holding it like this, so that say when you cough or sneeze, urethra pushes into that hammock. That hammock then physically pitches off the urethra and you don't leak. Okay? That is a more significant contribution to why you could hold urine than the actual sphincter muscle. Right? In this picture, what it's showing is that hammock is basically broken. Okay? You know, this should stretch from here to here. The fact that it's broken means that you don't have adequate support underneath the urethra. Hence, now that the hammock's hanging down here and you cough, it's now not pinching anything. And if you remember that Q-tip test, that's the reason we see that Q-tip jump is because now that hammock is not holding the way it should. All right, so where do we start with Mia? Okay, things that Mia could do to help her problem on her own. We kind of already talked about the weight loss, and how reduction of the pressure on her pelvis by losing the weight could help with her symptoms. She could also reduce her caffeine intake. And for some people, depending on how much caffeine they are drinking, it can make huge contributions here. I mean, there are plenty of people that I will have that come in with, you know, a history of coffee and soda similar to Mia's, that if you get them to stop their coffee or soda or frequently tea as well, they will have such a drastic reduction in their symptoms. It's like, oh yeah, I leak here or there, and I might wear a light pad here and there now, but it's kind of a precaution. So you can drastically improve their function by simply stopping the caffeine and convincing them to drink something like water, okay? Additionally, she could stop smoking, okay? Big issue with this, obviously, is treating the pulmonary issue. So she has enough damage to her lungs that she's chronically coughing and straining to breathe. Again, she's putting a lot of pressure on her pelvis, which is further aggravating her symptoms, okay? Now, in this specific circumstance, though, Mia has a job that's gonna cause her problems. And you can't just tell someone to go quit their job. That usually doesn't go very well. But something where you have a labor-intensive job where they're regularly having to lift and strain is going to aggravate the problem. So it then becomes an issue, okay, how can we address this in the context of what you also have to do for work? All right, and so next thing is, where do I start with her? What are things that I can institute to make some of her symptoms better? Okay, and I'm starting off with less invasive here. All right, so for instance, for Mia, medications might be a good start. All right, in the sense with her urge incontinence, those abnormal spasms that the bladder has, medications physically help to relax the response of the bladder to some of those abnormal reflex signals that it's getting and get it to hold urine better. Okay, as you can see, there are a lot of medications. You probably can guess the reason there are a lot of medications is because people can respond very differently to these, both in as far as effect as well as the side effects. Additionally, some people don't respond great at all, and so they come out with different ways of doing this with different receptor sensitivities to try and see if we can find a better avenue to treat this. with the medications, common side effects that we will see are usually dry mouth and constipation. I mean, if you've ever heard of Vesicare commercial on TV and they list all the side effects in, big ones that we will see are dry mouth, constipation. We'll also sometimes see some blurry vision. And then finally, in the elderly, one thing you have to be cognizant of or aware of is dementia issues. Some of these medications can actually worsen that, so you have to be careful using these medications sometimes. Now, there are some exceptions to that. For instance, this one Rebetric here works slightly different than the rest of them on the list. It works on a different kind of receptor, and we don't see those problems as frequently. I mean, particularly the dry mouth and constipation, because it's working on a different receptor, those are much less common. Then we get into physical therapy. Now, I will say, when I first mention physical therapy for somebody's pelvis, I usually get a raised eyebrow. You know, people are like, oh, I went and had physical therapy for my knee, and that was fine, but you want me to do physical therapy where? The other common response is, well, I do Kegel exercises. I've been doing Kegel exercises for years, and it's not getting me anywhere. And that's good, but physical therapy is more than just doing Kegel exercises. I mean, yes, you are working on those same set of muscles. Yes, you'll be doing exercises like Kegel exercises, but you'll also be doing it with different monitoring to determine that you're actually using those muscles appropriately. Because I can tell you, I see plenty of people that come in, it's like, oh, I do Kegel exercises, and you have them try and do a Kegel exercise, and as opposed to, say, clenching the pelvic floor, they might just be clenching their inner thigh. And that's not doing as much as the actual pelvic floor. Additionally, get them working on some of their triggers. So some of the things that are triggering their incontinence issues, like pulling into the driveway and things like that, have them start doing work to work on those specific triggers and get this better. And this physical therapy, I send a lot of people to physical therapy, okay? Because A, you're not having to take a medication, so you're not worried about the side effects of the medication, and B, it works. There are plenty of head-to-head studies that show that physical therapy is as effective as medication in treating this issue. So it makes a big difference. I would say particularly when we're talking about urge issues, it really makes a big difference. And usually the difference I will see quicker than, say, the stress. Stress, it definitely makes a difference. I would say roughly, some recent studies are saying about 65% improvement in stress urinary incontinence with physical therapy, but usually it's a little bit slower course. Okay, the physical therapy, and when you start working on those triggers with the urgency, we can see more drastic changes. I mean, and it can be one of those things that I'll have someone who's coming in initially and tells me they're up leaking 3 and 4 times per night, wearing a pad all the time, and they start doing the physical therapy and get to the point where it's like, I don't have to get up anymore. I'm not running to the bathroom, I'm not soaking pads anymore, and probably don't even need one in some circumstances. But I would say frequently probably wear a light liner because they've had years and years and years of not knowing when they were gonna leak and are now nervous to not do that. Final thing on this list is something called urodynamic testing, okay? Which is a big fancy way of saying I'm trying to figure out what the bladder's doing as it functions, okay? That's a test that we do in the office. I don't do it on everybody. It's reserved for more of someone who I'm trying to either tease apart somebody that has multiple different symptoms involved with their incontinence, or their whole clinical picture is more complicated. You know, so say someone who's had previous surgeries and had previous things done, and I'm really trying to tease apart, okay, how do I attack this problem that's going to be the most benefit for the patient, particularly when I'm seeing multiple different problems present? Okay, where am I going to get the most bang for my buck, essentially? So what urodynamic testing involves is using different pressure sensors and catheters that you place in the bladder and the vagina and different monitors on the muscles to see what's happening as you fill the bladder, as the bladder empties, and then try and do things to provoke it to leak to see, okay, what's really at play here? You know, there are plenty of times where, like, say with the retention issue that we kind of mentioned earlier, and people aren't as aware that they might be retaining. I can do physical or do urodynamic testing, and sometimes it really makes it evident that, oh, they don't have much sensation as their bladder fills. They don't empty it as well, and actually when they start to develop the incontinence, it's only because their bladder is at absolute peak capacity. However, when they came in and talked to me at the initial visit, it's one of those, well, when I get up, I start to leak, or if I cough too hard, I start to leak, and you're kind of thinking, well, maybe they have some stress incontinence. Maybe that abdominal pressure is causing leak. Well, no, actually, they're so full all the time and have no perception that they're that full, that it's almost like the pot sitting there full all the time, and the slightest tip causes it to spill over. All right, so with Mia, we tried Ditropan or Oxybutynin, which is a fairly common medication to start with. One, it's because it's been around the longest, and usually it's where the insurance companies like us to start. Typically, you have to show failure on this medication before we can move on to others. So she tried that. She said it helped a little bit. You know, she's not having to get up as much, for instance, or the urgency is a little less. Maybe she's having fewer episodes of incontinence per day, but it's not great. She also says that her mouth, again, like she had said when she tried medication before, is dry all the time. And she's tried using Biotine mouthwash, and she's drinking all the time, and maybe she's even trying to drink water to help it, but still a problem. Also, in her case, and for the sake of our conversation today, she tried physical therapy. It worked some, but it's not doing it all. Okay? There are plenty of people that we can start these two modalities of treatment, and that's like, okay, we're good and can stop and just follow. You know, again, for the sake of our conversation today, to make this a little more complicated, it didn't work great for her. Okay, again, she's seeing still the problems with the urgency, still the problems where she can't make it to the bathroom quick enough. On her urodynamic testing, one of the things that really stood out is she had severe stress incontinence. So what I mean by that is I partially filled her bladder, we stopped the filling, I had her bear down and cough with the different monitors, and I can actually tell, okay, how much pressure does it take on her bladder to actually cause her to start leaking? At what point does it kind of break the seal there? And in her case, it didn't take very much, okay? Just a little bit of pressure on her bladder caused her to start leaking uncontrollably. The other thing that was important to note with her is the actual sphincter muscle at the bladder neck. The urethral sphincter was working fine. So again, getting back to our point, the sphincter is not what's controlling how well you can hold the urine. Her sphincter, in this circumstance, worked great, but she still leaks really easy, and that's because the urethra doesn't have good enough support. The other big thing that stood out is as Mia was filling, we got to about 5 ounces or 150 milliliters, and I could spontaneously start seeing her bladder go into spasm. So I've got the monitor in front of me, I'm seeing what all the pressures are doing, and usually what I'll start seeing is that little pressure sensor in the bladder start to climb, and then usually within maybe 10 or 15 seconds, all of a sudden, patient's saying, I kind of feel like I gotta pee now, it's getting really bad. And it's because her bladder, just in the process of that filling, starts to have those reflex spasms that she can't control. Other good thing, sorry, I didn't want to jump there. Other thing that I've kind of touched on already that we try and rule out and ascertain when we do this kind of testing is, are there any issues with her emptying? And in her case, she empties fine. You know, bladder does its job of contracting completely, empties the urine out. She doesn't have a substantial residual, which, you know, as we've talked about before, can be a major factor then. And if there was a high residual, then how do we approach the problem? All right, so with Mia, first step we tried here was we put in a sling, okay? Her stress incontinence was really bad. With her job, she lifts all day. That's a significant contributor to her leakage. And if we don't do something to support that bladder neck well, she's gonna continue to leak. Okay, now, obviously there's a lot of press about the slings, okay, and I will say there's a few different issues to touch on here. One, the slings that actually work are synthetic. We've tried different slings that are, you know, there's slings that you can actually harvest from your own tissue, like the section on your leg, your abdominal wall here, or ones that are made from different dermises or cadaveric tissue to help support that. Those tend to break down more and don't have as good long-term effect, okay? The synthetic ones, when we put them in, hold up well and hold up there for a long time. One of the issues that we're having with slings is that it can have complications sometimes, okay? It does happen, just like complications occur with other procedures. The catch is what I might call a sling is not necessarily what someone else calls a sling. So for instance, there's a big difference between a sling versus a transvaginal mesh that's used to treat prolapse. And there are a lot of people that will come in and say, oh, I had a sling done and I'm having problems. And in actuality, they didn't have this little sling that's maybe about this long and a centimeter wide. They have a whole sheet of mesh in their pelvis holding everything up. But they'll still get thrown in and say, I had a sling and it caused all kinds of problems. Very different issues, actually. So for instance, when we actually talk about a true sling, synthetic sling that's right now considered gold standard for treatment. Generally, we have about an 85% success rate. So, and by that success rate, I mean they're not leaking, okay? You probably have about another 5 or 10% that leak a little bit, but still substantially improved. As far as the complications, when we strictly talk about slings as far as a major complication, and what I'm considering more of a major complication is I have to go back and do something to this sling because it's not doing what it's intended to do. Either they're leaking too much, or it's too tight in there and we have to take it out, or it's causing a pain issue, or it's wearing through an area in the vaginal wall, okay? The likelihood of that happening is about 2 to 4%, which when you compare that actually to other ways that we could surgically fix incontinence is not a bad number. The other ways that we use to fix incontinence actually have higher complication rates and lower success rates. So when we're looking at options, the reason this is considered kind of a gold standard right now is because we can't do anything better to actually treat the incontinence, and the number of times we're having a problem with it can't be beat. This surgery is outpatient. So if we're just talking about placement of a true sling to treat incontinence, it's an outpatient surgery. Now, if you have someone that you know that's had a sling and then been kept overnight and had a longer recovery, it's probably because they actually had prolapse repaired, which is a different circumstance again. So this surgery, come in, you go home same day. Generally, it takes about 15 or 20 minutes to do. You know, the sling specifically that I'm showing a picture of here, actually you make a single incision inside the vagina. It's only a couple centimeters at most in length. Place the sling, sew up that one incision, you go home. You know, there are a few other slings. You can hang these in different ways. Some of them actually will come out and puncture through the sides here. Some of them will come out and puncture through the top, but they're still little tiny incisions. So still it's the same day kind of surgery. As far as what to expect after a sling, generally you might have some mild discomfort. It's usually not severe pain. I'd say that's a rare exception. Additionally, you have to be a little bit cautious about lifting and sexual activity. I mean, putting the sling there, the idea is not that that sling is just doing everything on its own. It's actually your ability to heal into the sling and incorporate it that makes it hold long term. So I want this to stay where it's supposed to be and not try and migrate too tight or too loose as it's healing in. So, you know, in a case like Mia's where she has a very labor-intensive job, we might have her off of work for 2 to 4 weeks so she can avoid having to lift and strain and pulling that sling out. All right, so Mia does her sling. It helps her stress. Stress incontinence is gone. She can now lift and cough and sneeze and not cross her legs, and things are going well in that regard. However, she is still having the urgency issues. She is still up 3 and 4 times a night having to go to the bathroom. She still pulls into her driveway and can't make it into the house fast enough. And that's, again, different causes of incontinence and we have to address, okay? So, next option that we consider trying with her is something called posterior tibial neuromodulation, which is kind of a mouthful for saying we stimulate the nerve that's here behind your ankle using an acupuncture needle and a little stimulator, okay? The reason we stimulate that nerve behind your ankle is it actually shares the same nerve root as your bladder. So we can stimulate that nerve, basically just use it as a jumper cable to get to your bladder, stimulate that nerve, and then that nerve gets better control of bladder function. And we can use that to treat both urge issues as well as retention issues. The big catch with this is that it's something that takes time and it does take maintenance. Okay? This is not a one and done approach to treatment. All right? So for instance, when we start this kind of treatment, you're coming in once a week, usually for 12 weeks. The treatments are about 30 minutes. So, I mean, literally in my office, I have a lazy boy set up in a room. Bring them in there, pop their feet up in the lazy boy, tell them to bring something to read, put the acupuncture needle behind their ankle, and start things going. Okay? Typically, once you've completed the 12 weeks, you have to come in, and it varies. I have some patients that have to come in every 4 to 6 weeks, some patients that can come in every 3 to 4 months to kind of maintain that benefit. But it's something that's not just you do it and it's all better and it's just going to stay that way. Okay? But the big advantage is, and I'd say particularly in someone who is not really keen on going either back to surgery because they've had previously or previously had something done, or they're just not a great surgical candidate in the first place, there's no surgery here, okay? You're literally just putting in an acupuncture needle. There's not significant risk for complications. We're not having to go like put something in or undo it or deal with anesthesia or any of that. So Mia did that, didn't work great, better but not great, which is a good sign. It tells us, okay, if we stimulate that nerve, things are actually getting better. So should we do more because she's still having enough of a problem? So that jumps us to the next step, which is sacral neuromodulation, okay? As opposed to using that nerve in your ankle as a jumper cable, we're now actually going straight to the root of the nerve of your bladder. So with this procedure, you're actually placing a wire straight into the tailbone. There's these little holes where the nerve goes through. Finding that hole, placing the wire there, and directly stimulate that nerve. It usually involves a trial test where we put like a temporary wire in there that you just place with a needle. So a little bit of sedation, place the wire with the needle, leave that wire in there for about a week and with a stimulator that is external, and see if we get the kind of response we want. If we get that response, then we come back and put the actual wire in. Now, I've got a picture on the next slide of what that is, but that actual wire then goes in, traces under the skin, and we have it basically go to a pacemaker battery that you can program with a remote externally. Okay, so it is literally a pacemaker battery when you look at it. I mean, it's about yay big around, about that thick. You know, like any battery, we have to change it periodically. So if we go with this route, usually we're changing the battery about once every 5 years. Okay? As far as improvement of incontinence, it hovers around 90%. So and with urge issues, that's not bad. Urge issues where the bladder is abnormally spasming, and particularly if we're getting to the step where we're having to stimulate the nerves, means they've failed a number of other things. So getting improvement in 90% is a pretty good number. Now actual cure, meaning they're not leaking at all and don't have to rely on a pad, is roughly about 50%. All right, so this is showing a picture of sacral neuromodulation. It's a device called the InterStim. Okay, so this is the pacemaker battery. It's under the skin. Wire then traced down under the skin into that little hole in the tailbone I was talking about and lays on the root of the nerve that then stimulates the bladder. And we can use a remote, an external remote, and we can change the settings, so how much stimulation are we providing, and also there's a number of different contact points on this wire, so we can individually adjust which contact point we're stimulating and slightly modify the response. I know, a lot of cringe faces. Again, the good thing about this one though is like it's a you do it, you go home. So as far as when we're talking about incisions, literally the wire itself for the most part is placed with a needle. So it's a needle poke. I make a little nick incision to pass the wire down through that, and then this pacemaker pocket is one incision off to the side about that big. So as far as invasiveness, it's not terribly invasive. All right, so now, what do we do if it doesn't work? Okay, what's next? Because obviously we're running out of potential options. Now, fortunately with me, I had it work. Okay, so next step if it doesn't work is Botox. I don't know if any of you have heard of that, but just like you could use Botox in your forehead to get rid of the wrinkles, you know, that Botox goes in there and paralyzes the muscle, makes it so the muscle relaxes. So if you're having abnormal spasms of your bladder, we're physically putting a chemical in there that blocks the ability of it to spasm, okay? It works, okay? The bad thing about it is it's not a one and done either. So when you put Botox, I don't know if any of you have had Botox, say, cosmetically, but usually the effects of it you might have for about 6 months, maybe 9, but then things start to come back because that chemical that's blocking those receptors and preventing your bladder from spasming eventually goes away. And so it has to be redone periodically. So this is showing a picture. It's an outpatient surgery procedure. You come in with a camera that goes into the bladder, and then this is showing where you inject. So you generally do about 20 different little injections along the base of the bladder to make that area relax. Okay? Now, reasons we don't sometimes just jump to this is when you compare this to, say, the InterStim, there is a higher incidence of urinary tract infections. And the reason is because sometimes that Botox works too well. Okay, it relaxes the bladder too much, and then the bladder doesn't empty appropriately. If it's bad enough, sometimes people that do the Botox will have to catheterize themselves for a period of time because the bladder won't empty at all. The muscle physically is too impaired to empty. So a person that you absolutely don't do Botox on is someone who's not able to catheterize before the surgery. So it's one of those, you gotta be able to self-cath and be willing to do that if you go this route. All right, so this is Mia after treatment, okay? Everything works. She gave 5 stars on all the health grade stuff. The administrators are all really happy. She obviously started exercising, lost weight, and stopped smoking because she actually listened, and she's great. All right, on to our second patient. Second patient is Emma Fallon, okay? So Emma comes in with another really common complaint that there's something hanging down there. Okay. Now I will tell you that probably 80% of the people that I have come into clinic with a similar kind of complaint will tell me their bladder has fallen because they assume it's always got to be their bladder if it's something down there is falling, which is not necessarily the case. Okay. So when you get specific with Emma, she says she feels a large balloon down there. It's protruding all the time. It's rubbing on her clothes. It might bleed. It might cause increases in discharge. It's definitely causing increases in discomfort. She says it's been there for a number of years, and that's not uncommon. I would say most people that have an issue like this will have some sensation that there is something down there, and then they might do something, all of a sudden you notice like, oh my, it's really there. Okay, so kind of thing where they might have known that there's something going on for the last 3 or 4 years, and then all of a sudden it kind of crosses a threshold and is now causing too much of a problem that they really want to get this treated. I'd say that's a really important point when we talk about treating pelvic floor issues in general. Okay, so like let's say somebody comes into my office and is just there for routine examination, and I happen to notice that there's a little prolapse, a little something fallen down. Okay. If they have no sensation of it, if it is not causing them any impairment, if it's not causing them any problems, it is one of those things that we will typically just watch. Because me going in to fix it puts them at risk for potential complications and further surgeries and whatnot. And if they're not having a problem in the first place, even though it's there, what benefit do I really do them in going to fix it? Besides the fact that when I happen to look there, it looks like it's where it's supposed to be. So with this kind of issue, generally you wait till it's causing enough of a problem that it needs to be addressed. And that's kind of up to the patient, okay? How we grade what we respond based on these is a lot of the sense, okay, how much of a problem is this causing you? Is that problem big enough that it warrants the solution? One thing with Emma, I point this out specifically, so Emma doesn't feel like she empties well, okay? Sometimes when things are falling, it also drops down below that pelvic floor and makes it more difficult to empty your bladder. I'm going to highlight this with some pictures here in a few slides. One of the complaints that we'll sometimes also hear is that someone's had problems with incontinence in the past, but now it's all of a sudden better. Okay, so it's the kind of thing, she might have noticed that when she kind of had a sensation of something there, but not really bad, that she would regularly leak when she cough or sneeze, and she couldn't jump on the trampoline with her grandkids or whatnot. But now in the last 6 months, it seems like that's all gotten better, and she's never leaking. And that's it. As things have fallen, it's actually made it so that her bladder won't leak. And again, I'll highlight that here in a few slides. The other thing that we'll commonly see, particularly when there's some difficulty emptying your bladder, and I kind of talked about this a little before with Mia, was that you can have recurrent urinary tract infections. So if your bladder is not emptying well, it's leaving fluid in there that then makes a nice place for bacteria to grow. You know, one of the great things about a bladder in general is that if, like, let's say an abscess pocket that you have somewhere else in your body, one of the big treatments for treating an abscess is you drain the abscess, okay? Bladder drains itself most of the time, so you don't have those kind of concerns as frequently, and hence people with urinary tract infections can sometimes just do, oh, a short course of antibiotics and you're good. When you're not emptying your bladder though, well, basically it's kind of like having an abscess in there and that fluid is not draining appropriate, and so it's this culture medium just to let things grow. So commonly when we'll have people that come in with severe prolapse that is causing retention issues, they might be getting treated for infections every month, kind of thing. They'll clear it, they feel like they're clear for a week, and then a week later, they're back to having some kind of symptoms again. They're just on antibiotic after antibiotic after antibiotic. All right, again, looking at Emma's medical history, I'm basically, again, looking for, do I identify risk factors, okay? As you see, Emma is a little older than Mia, which I would say generally we see more prolapse issues which occur the older you get. She's married, mother of two, and I would say her lifestyle is quite a bit different than Mia's, okay? She is pretty active. She was involved in various fitness competitions, which actually can be a risk factor for some of this. She reports that her mom had the same kind of problems, okay? So the issue with prolapse, and we see this with incontinence too, is we talked about the pelvic floor and how some of that function is connective tissue, right? Connective tissue is also something that genetically is determined, and how strong that connective tissue is and how well it holds impacts these kinds of issues. So, and that's not necessarily just something we'll see in your mother. Like in this circumstance, I said, oh yeah, her mom had problems like this as well. But I can have patients that come in that are having issues with prolapse or incontinence, and they'll actually tell me, oh, their dad's had multiple hernia surgeries. Basically the stuff that holds them together is not quite as strong as it could be, and that manifests itself in different ways. With Emma, first delivery was also difficult, and in her case, it wasn't necessarily a big baby, but they had to use forceps or an instrument to help get the baby out, and she had a big tear. So obviously we know that there's been some kind of trauma to the pelvis that has now had to heal. She doesn't smoke, and the final thing, she also works at Ford. Okay, so she's lifting all the time, she's straining all the time, she's putting pressure on her pelvis all the time. So if we have weakness in the pelvic floor, obviously it can contribute to things falling down. The other interesting thing to point out, I would just say, is as far as how people hear about this kind of problem. Okay, and there's a yoga studio up north here that I specifically can reference. But I saw one person from this certain yoga studio. We dealt with some of her issues and treated it. And then subsequently, I had a number of other people who was like, oh, I know blank. And I know that she had some things treated because, she was out of yoga for about 6 weeks after surgery, and then went back, and people would ask her what happened, and it's like, oh, I have that problem too, like, what can I do? And so you see this little chain of like, oh, I know someone that knew someone that knew someone that knew someone, and eventually comes in to get treated. All right, with Emma, there are a few things that she has tried, okay? In general, this is not common in the sense that people want to hold off getting this addressed. I would say that's particularly prevalent in the recent years where you've seen some of the commercials on TV and everyone thinks, oh, to address this means I have to put in one of those meshes, and oh, I don't want to be one of those commercials, basically. That's not necessarily the case, but you see a lot of people nervous about addressing it. And honestly, people sometimes feel pretty awkward addressing this. I mean, that's understandable. Sometimes people will come in and have had tried, insert things again, but pessaries. So this is a picture of pessaries, okay? These are made out of silicone. They go in the vagina, and they basically help support whatever it is that's falling down within the pelvic floor. So it's kind of like coming in and getting fit for a diaphragm, in a sense that you come in, we try different sizes, different shapes based on how things are falling, see what holds, see what doesn't, and see how well you do with it, okay? This is something that does require regular maintenance, so you're coming in for regular visits to check on this, to make sure it's holding the way it should, that you're not getting any infections, that it's not wearing funny in there, and that everything's going well. So typically, I would say, I will fit one of these, see you a couple weeks later, make sure it's working okay, maybe see a couple months after that, make sure everything's still stable, and then depending on which one of these we use and how you're doing with it, it could be anywhere from every 3 months to 6 months that we're having you come back just to check on it and make sure everything's fine. The other thing, and we kind of talked about this a little earlier, that say Emma's tried, is she's tried Kegels, but we kind of addressed how successful is that is sometimes hard to gauge, just based on what someone says. The other thing that she does routinely is she does something that we call splinting. So when things are falling, you push up the area that's falling to help get the bladder to either start urinating or to help have bowel movements. And that's because you're basically reducing an area that's this abnormal pocket so that it can then function more normally, basically putting it back into the pelvis. All right, on examination, we'll just start with the picture since it's pretty pronounced. So again, just orientation, Front of Emma is over here, so she's looking straight to your right, okay, back of your bottom. So as opposed to the uterus being up here, it's down here, okay? And this is a circumstance where basically everything is falling out. So again, her bladder should be right here. Instead, it's down here. Now the rectum in this picture is not so bad. And usually when we have something like this, the rectum will be protruding, but it kind of falls in right behind the uterus. It's usually not like the bladder, which, you know, the bladder is fixed more down at this point in the uterus. So when the uterus really drops like this, it pulls the bladder down with it, okay? When we look at her exam, she's not having obesity issues, but, you know, circumstances like this can help. You know, again, check for a urinary tract infection. The other thing I check, and usually there's two ways of doing this. So we can check for retention in the office, and we can either use an ultrasound probe to kind of look and see how much fluid's in the bladder. The other way that I will commonly like to try and do it is I actually put a skinny little catheter into the bladder to physically drain it and see how much is there. But also the reason I do that is I can ascertain, is there something inside the urethra that's causing a problem, might be contributing to the symptoms. You know, how well does this catheter actually pass? You know, like for instance, if you tried to put a catheter here in Emma, you would start putting it in, quickly hit this point where it takes a right turn, and know that, oh, she might not be emptying her bladder well because this spot is literally pinching off. You know, this should not make a right turn here. This should be going up and in there like that, more of a straight shot. The other thing when I have prolapse issues like this, frequently I'll push things back in so that they're sitting more where they should, and then try and see if we can provoke leakage. So if you recall, Emma said she used to leak but now doesn't. Okay. Basically I'm saying, okay, we put this back where it's supposed to be, now do you leak? And in the circumstance here, you know, we put things back and she clearly started to leak. Okay. Getting back to this idea where we have this kink here. It's just like your kink in the garden hose. Okay. You know, when you kink the garden hose, the water doesn't come out. You straighten that garden hose out, all of a sudden water starts to flow. Hence, as her prolapse got worse, as this kink got worse, it actually stopped her from having incontinence. But on the flip side, she's now retaining urine. All right, so what do we think is going on here with Emma? It's pretty straightforward. You know, you can tell from the picture, she has what we'd either call uterine procedentia or stage 4 prolapse, which is basically two different ways of saying kind of everything has fallen down to the maximum level. She also has occult urinary incontinence, which does not mean she's joined some weird religious sect that worships leaky bladders. This is basically that phenomenon where her incontinence is being hidden by the fact that her prolapse is severe. Okay, because of that kink is preventing her from leaking. If you were to take out that kink, you basically unmask the fact that she would leak otherwise. And then obviously, you know, she's having significant retention issues because of that kink, and then as a result of the retention, she's having frequent urinary tract infections. So where do we start here? So let's talk about prolapse, okay? When I'm looking at pelvic organ prolapse, I'm basically trying to figure out where is the weakness, okay? Because, you know, multiple different organs in your pelvis, multiple different points where the support can break down, hence multiple different approaches to trying to treat it. Okay? It's not, you know, like I said, most people that come into my office tell me that their bladder's fallen, even though it might be any other number of things are fallen. So I'm trying to figure out where did things fall and then how do we fix it from there. Okay, so back to our similar pictures. You guys, I hope, are familiar with these by now. So in this picture is what is called a Sistah Seal. Okay, so here, as opposed to the bladder being held up well, is basically bulging forward into the vagina. Now, one fear that I have patients come in is they think, oh, my bladder's fallen, or they've been told that their bladder's falling, and they think their bladder is physically what's protruding. And then they're worried about hygiene issues because they think the wall of their bladder's out. It's actually, this is like a hernia. Think of these like hernias. So it's actually the lining of the vagina that's protruding, the front wall of the vagina, but the bladder is pushing down behind it. And basically herniating in this picture at this point. Okay? More of what Emma has going on here is what we consider uterine or apical prolapse. Okay, that means the top. So support at the top of the vagina has broken down, and so things are falling down, and it starts from the top. So in this picture, uterus has fallen down, similar to what Emma has. However, we will frequently see issues in women that have actually had hysterectomies. Okay, and that's because the organ is not necessarily the problem. this supports the problem. So for instance, if you've had a hysterectomy and the vagina itself is fallen, it's actually the small intestines usually that are what's pushing down here. Okay, again, the problem is the support. And that's something I'll commonly have people come in and say is, oh, if my uterus is falling down, why don't we just take out my uterus and that will fix the problem? Well, because it won't fix the problem, because the top of the vagina is still not supported like it should be, and hence the top of the vagina will just be hanging down even though there's no uterus there anymore. Final thing here is what we call a rectal seal. So basically, as opposed to a hernia under the bladder, you basically have something that's like a hernia along the back wall. Okay, so the rectum protrudes forward, and with this we'll commonly see a lot of different constipation issues or issues feeling like you can't completely empty. Okay, and this is where I will say more commonly I will hear people that will splint. So the rectum will bulge forward, fills up with stool, and the only way to get things really empty is they have to push that bulge back, because basically this bulge is like a low pressure pocket, and they might be bearing down to try and empty, but it just pushes that pocket forward as opposed to eliminating. And this picture I kind of like, and this kind of gets back to, okay, where is the weak spot? So we've talked about, okay, what organs are falling down here. This picture, and it doesn't show as well in this picture, but this picture actually gets to the support. Okay, so if you think of your pelvic floor almost like a bowl, there's hammocks that hang across that bowl over the vagina that help hold up the different organs, essentially. So for instance, you have these different levels, and it's level 1, 2, and 3 here, where these hammocks are holding things up. So typically, level 1, we're talking more about what's holding up the uterus and top of the vagina. Level 2 is basically this plane that fits underneath the bladder. It's like the sheath that basically supports the bladder and its base up. And level 3 is getting down more towards the actual pelvic floor itself and more towards the urethra. All right, in regards to occult urinary incontinence, okay, this picture kind of using to highlight that, again, prolapse is bad. Here, this picture, the bladder is falling down, and basically you have a kink that's formed in the urethra not letting the urine out. When you push this back up and straighten this back out, you start to leak. Okay, so again, it goes against that myth that a leaky bladder is probably leaky because it's fallen. In this circumstance, actually, the fallen bladder is helping prevent it from leak. Putting this back in, like so say we go do surgery to fix this, can actually worsen the incontinence issues. I actually can calculate some of that risk, and I did this with Emma specifically. So if we were to repair Emma's prolapse but not address her incontinence issues or potential for the incontinence issues, she's got about a 34% chance that she starts to leak afterwards. If you do something to address the incontinence issues specifically, like put in a sling, it drops that down to about 7. So it's one of those things when I'm talking to a patient about, okay, we're gonna go fix your prolapse, okay, I have to be very aware of like, okay, am I addressing potential incontinence issues? Because I could actually, I don't want someone coming in 2 weeks after we fix their prolapse and everything is great with the prolapse, but they can't leave the bathroom because they're leaking so much. Not doing anybody any good there. All right, so with Emma, what do we start with doing? So basic things, lifting and straining are going to worsen her symptoms. Again, with her job, that could be a problem. To help reduce some of her retention issues, you might encourage her to splint. You might encourage her to push things back in so that she can more effectively empty her bladder and basically take that kink out. There's also these things called squatty potties, which can be handy. So squatty potty is basically a stool that's designed to sit in front of the toilet. You put your feet on it, it changes the angle of your pelvis, and then can help eliminate better. For people that have really bad problems with incontinence, we might have them or teach them how to self-catheterize, because until they empty their bladder well, it might be that they continue to have infection after infection after infection. And actually, the catheterization could help with that. Okay? Now, in Emma's circumstance, her prolapse is severe. I mean, we could do all of that. I would guarantee you with prolapse as bad as hers was in that picture, she's going to have a hard time self-catheterizing, so we're probably talking about methods of treating it. Before surgery, it's not uncommon that we will start estrogen cream. Okay, a couple different reasons. One, it makes the vagina actually a better barrier to the infections. So the vagina itself works better to prevent the infections. 2, it improves the thickness of the vaginal wall and blood flow to the vaginal wall, which if we're starting to talk about surgery, is going to help her heal. The other thing here is we might put her on a course of antibiotics. We have a really low dose, say once a day, to prevent her from getting these infection after infection after infection while we're trying to deal with her other issues. Okay? We might send her for physical therapy, and this is somewhat dependent on degree. I would say with Emma, as bad as things were, physical therapy probably wouldn't do as much, but particularly someone that has lesser degrees of prolapse, the physical therapy won't necessarily make the prolapse magically disappear, because again, we're talking about a support issue that's not all muscular, but it can significantly reduce the symptoms for some people, and it might be that physical therapy is all we got to do. And then finally, what we're going to talk about next is actually surgical approaches to deal with what Emma has. All right. Two different approaches I'm outlining here to talk about Emma. Now, there are other ways to do this. Okay, this is not all-inclusive for treating all prolapse. We're talking about prolapse that Emma has. It was really severe, so I kind of went, okay, these are the big guns. One is called sacrocolpoplexy. So literally, you're using a synthetic mesh, going in abdominally, and I frequently will use a robot to do this, tying that mesh to the tailbone, bringing it down to the vagina, and laying it along the front and the back of the vagina so it pulls it up. Okay? The other approach here is something called a colpoclesis. Okay? This is quite a bit different. So this actually doesn't use any kind of foreign body. This, as opposed to being an abdominal procedure, is a vaginal procedure. Okay? What you do with this is you start where the vagina is protruding and then start sequentially kind of closing and closing and closing and closing it until it's reduced all the way, and you get to that level of the pelvic floor and then close the pelvic floor itself. All right, so what makes one better than the other? All right. Sacrocolpoplexy has a low likelihood for recurrence. One of the big issues we deal with when we're talking about prolapse surgeries is the likelihood that things come back. Okay, because you're dealing with compromised tissue in the first place. So kind of think if you were wearing an old pair of jeans and the knees are worn out. Okay, you can go stitch up that knee where it's torn through, but you're still dealing with denim in the sense it's thin and frayed. So recurrence rates are definitely something we deal with, hence there's all these other things that we try and do to lower that rate. All right, so sacrocolpoplexy definitely lowers that recurrence rate. Okay, generally we're talking about 5 to 10% risk of recurrence. It is a big surgery though. I would say when we're talking about the surgery, it's probably, if we're just doing a sacrocolpoplexy, it might be 2 to 3 hours. If we're having to also do hysterectomies and some other components of repair, it could be a 3.5 to 4 hour procedure. Now you are in the hospital overnight, you usually go home the next day, but it's not minor. We do use a synthetic mesh, so we do have to be cautious about how that's used. Now again, synthetic mesh that we talked about, the scary stuff is what you might place going from a vaginal approach. This actually, placing it from an abdominal approach makes the side effect profile much different. So yes, it can cause problems, but the likelihood of it causing those problems is much less. And so if you're weighing how likely is it that I take someone back to surgery versus how likely is it that we end up having to go deal with a mesh issue, it's less likely you're going to end up back in surgery because it's so much less likely to get the recurrence. We have to watch the mesh issue, but it doesn't happen as frequently as it does if we use mesh in other ways. The other big thing with a sacrocolpoplexy is it restores sexual function. So basically, we're putting the vagina back in the position it's supposed to be so that you can still have intercourse. Okay? Now, this is in stark contrast to the colpoclesis. Okay? With the colpoclesis, we literally kind of close down the vagina. We obliterate it, so externally everything is still normal. Internally, though, the vagina basically stops at the pelvic floor. Okay? Hence, you can't have intercourse. But the catch is, if you have someone who's not sexually active, there is no procedure that has a lower recurrence rate. Okay, it wins. The other catch is it's not using anything foreign, it's not as invasive, so when we're looking at overall complication rates, nothing beats it for a complication rate. So if you have someone with really severe prolapse that is no longer sexually active, generally this is going to be a win. So actually with Emma in this circumstance, she decided to go with the sacrocolpoplexy because of sexual activity usually in most circumstances, or just wanting to maintain the possibility. I mean, there are plenty of people we'll see that might not be sexually active, but part of the reason they're not sexually active is because of the degree of their prolapse. And once we repair that, that goes back to normal. In her case, though, with the uterus there, we will frequently do a hysterectomy, okay? But we leave the cervix behind. You're thinking, why in the world would you bother leaving the cervix? The reason is that by leaving the cervix, we actually don't make an incision into the vagina. Completely stay out of that, and that helps lower some of our complication rates that you can get because of mesh issues. So it's a way that we can manage complications. And as I pointed out, Emma had the occult urinary incontinence, so we're putting a sling in her because she'd be one that if we just fixed her prolapse and pulled everything back up, it's going to pull up, but then she's going to come into my office and not be very happy with me because she's now leaking all the time. So that's showing a picture of what the mesh is with the cervix left behind. So again, tying the mesh to the tailbone, goes along the front and the back of the vagina. In this case, uterus used to be here. We left the cervix, put the mesh around it. I'm just trying to highlight a point here. So if you recall, Emma was in fitness competitions, which actually heavy lifting is a risk factor for prolapse issues. I've specifically seen patients that were competitive power lifters and coming in because of this kind of problem exactly. Okay, so I can go in and I can do the best repair in the world and it healed great, working great, but it's still fundamentally an area that we have some concerns because it broke down once in the first place. So if you were to go back to, say, your powerlifting or really heavy things like that, I would have some concerns. And generally, like those people I've had that have been competitive powerlifters, it had to be one of those conversations. We're going to have to find some other sport for you to get involved with because this is going to make it fall down again. It's just going to put you at higher risk for that happening. All right, and with that, all finished up and answer any questions.
Thank you all for attending. Skip Dr. Rosbrugh.